Hi, I'm Caryn Zinn, Professor of Nutrition at AUT and dietitian.
And I'm Marcus Hawkins, a general practitioner in South East Auckland.
Thanks for joining me today, Marcus. We're just going to have a little bit of Q&A that will help those who are watching. And what we're going to talk about are basically myths and misconceptions about therapeutic carbohydrate reduction, or in other words, the low carb approach to managing certain conditions. So I want to kick off with a question which is probably on most GPs' radar when low carb is kind of mentioned, or when keto is mentioned, and that is about the issue around lipids and LDL cholesterol and cardiovascular disease. So can you just tell me about whether it's safe, doing low carb is safe for cardiovascular disease, and what some of the issues are there?
Yeah, I mean, the elephant in the room is the lipid profile. What happens to that? And, you know, we're supposed to be eating a higher fat diet with low carb as a rule, not always, but that's generally the sort of perception and often the case. And what studies have shown is actually the lipid profile will often improve. Certainly in terms of triglycerides, they will often normalize, which is amazing because in our current dietary pattern, they're often slightly elevated or very high. So that's the first number one. That's an independent issue in terms of cardiovascular risk. And then you're looking at things like your HDL and your LDL. So the HDL will often improve to some degree. Your LDL will often stay the same or may increase. Now, I'll just comment on that because the reason it increases typically with a low carb way of eating, what happens is you produce more of a certain subfraction of LDL. There are 7 subfractions of LDL. There's a small dense LDL, which is harmful, and the large buoyant LDL, which is good. What we know is that when you go low carb, the large buoyant LDL increases, and hence your LDL may increase a bit, and that's a good raised LDL. We know that small dense LDL represents typically oxidized LDL, harmful LDL, not good, risk of heart disease and stroke. And just as an interesting point, with the standard American diet, or a diet that we're supposed to be following, you actually produce more small dense LDL than buoyant LDL. So in actual fact, that's more of a harmful profile. So the LDL will often stay the same or may increase slightly. And that also depends on what your perception is of LDL in the first place as a risk factor for heart disease. So a useful parameter or way of assessing the small dense versus buoyant LDL is to look at your ratio of triglycerides to HDL. And if that ratio is less than 1.3, you've got a good number of, or a good count of buoyant LDL. So you can actually do a quick reckoning on your lipid profile to see if there's an issue there. Now, in some people,
can I just interrupt and ask you that ratio, is that so your HDL and triglycerides are used as proxies? Is that because when you test for your standard lipid panel, you just get LDL, and it's only when you go towards more of that comprehensive, integrative, medical, expensive testing do you look at the different subfractions of LDL, which is not common practice in our current system?
Correct. Yeah. I mean, you can actually obtain those tests, and I've done that previously with patients, but it's expensive, and you don't actually need to do that. You've got a good surrogate, and there's a good mechanism whereby Paul Mason talks about how the lower triglyceride to HDL ratio represents more buoyant LDL. So that is actually shown in Science in some papers. So it's useful from that perspective.
Great.
Now, I just wanted to comment on a subgroup of patients, so-called lean mass hyper-responders. These are some people who are lean, typically very athletic, and they have a specific pattern of lipids, very low triglycerides, raised HDL, and high LDL. And you can see LDL sort of in the tens, and you can see total cholesterol therefore, because it's made up of the composite of the other subfractions, you know, LDL and triglycerides, etc. So your cholesterol will be sky high, and we don't actually know what the risk is of that profile. And there's theories about energy flux and how that might be causing the LDL to elevate to that degree. So there's often a large degree of uncertainty in terms of how to proceed with that, what to do about that. And that's very much a patient-driven decision, I think, in that regard, because we don't know as doctors, as scientists, what the risk is. We can assume or we can hypothesize, but there is a subgroup where the LDL will go up to 10, 15, and that's a scary thing for most doctors and an evolving area of science. So just to mention that, and if that occurs, I think one has to have a discussion, probably with a practitioner who's familiar with doing this.
Yeah. So any other kind of nuanced testing like calcium scores or
Oh yeah,
CTA? Yeah.
absolutely. I do a lot of calcium scores, chronic
Yeah.
calcium scores. They're fantastic in
Mm-hmm.
terms of assessing whether or not one should maybe be on medication for prevention of heart disease and stroke. So you can obtain those privately for about $650 in Auckland, and they will tell you how much calcium is in your coronary arteries. And a score of 100 plus or a greater than 75th percentile score for age will mean that you should be on some medication to improve your outcome of heart disease and stroke, risk of heart disease and stroke. What we know is that if people have a score of that magnitude or greater than 75th percentile, then we know that statin and an aspirin will often prevent events from occurring. Now, it's not necessarily thought that it's an effect on the LDL or cholesterol, maybe an anti-inflammatory effect, maybe an anticoagulant effect, but the point is that we can show in a large study, the St. Francis Heart Study, that these instances of these events can be reduced or prevented by being on a statin. So it does work for those people. And it is very useful when someone has a very high lipid profile or strong family history to get a calcium score test done, because if their score test is 0, you really don't need to do anything for the next 5 years. And people have commented on this in online, where people like Asim Malhotra, you have someone who's got familial hypercholesterolemia, which is supposed to be a death sentence in inverted commas. Well, if it's got a score of 0 at the age of 60, then really you haven't got a condition that's going to cause you a problem because you've survived that long. The idea was that you have heart attacks in your early teens or before then, and you die young. But the interesting thing about that is these people have typically a very, very, very high cholesterol level. And if you live up to the age of 60, your risk of dying from heart disease is the same as everybody else. So the cholesterol can't really be an issue there.
Right. So can I just quickly summarize what I've heard you say? And that's when you look at the lipid panel in this kind of therapeutic carbohydrate reduction approach, you can't just look at LDL. You've got to look at the whole panel. You've got to look at what triglycerides are doing. You've got to look at what HDL is doing. You've got to look at the trend. You've got to look at the family history. And then if your LDL stays or drops, then, we're all happy. If the LDL goes up slightly, it doesn't necessarily mean you need to put people on a statin. There needs to be a conversation and potentially some further testing to look at the type of LDL and potentially what's happening in the arteries themselves before you can look at the management plan. So it's quite different from the kind of traditional view where everything's great, but your LDL is slightly raised and you slap a statin on. Would that summarize it okay?
Absolutely correct. And I mean, the way the guidelines work is that you don't just treat the cholesterol anyway, you treat the risk. Yeah. The risk is a composite of an algorithm, a composite of age, gender, ethnicity, smoking history, etc. And if it's above a certain level, you're supposed to stick someone on a statin. Well, if that percentage is greater than 5%, which is a cutoff essentially, you can get a calcium score done. If a calcium score is 0 or less than 100, or less than the 75th percentile, you don't need to go any further for another 5 years or 3 years perhaps if you want. So it's not as clear cut as it might seem. But there are tools that we can use. And the other thing is, an evolving area perhaps, is the whole area of LP little a and lipoprotein little a and ApoB100, is that, an elevated level of those parameters, as it were, increases your risk of heart disease and stroke. But what do you do about them? There's no actual effective way of treating them. There's a proposed cholesterol reduction, but, we don't know that actually works necessarily. So there's another avenue of investigation for raised cholesterol and looking at risk, again, can be mitigated by doing a calcium score, in the sense that if it's favorable, then you don't need to go any further for a while.
Yeah, great. So the lipid argument is quite complex, and you can see why GPs get a little bit sort of scratchy thinking about it, because it is quite different to how they've normally been, been thinking about things. But science is evolving, and I think these conversations definitely need to be had. So that was a really good summary. Thank you. Beyond cardiovascular disease, are there any other concerns or questions about long-term safety in general of going on low-carb dietary approaches?
In terms of having had a previous heart attack or stroke, I think the evidence is out there, and I can't quote it off the top of my head, but I've certainly seen it and studied it. The evidence is there that you can safely go on this way of eating without risk of further events. It's actually not going to be detrimental to your health. As I mentioned, you improve some of the parameters anyway, and usually you're on medication to prevent further events occurring. So, we're talking about metabolic health. We're talking about obesity, which is often still present even if you've had a heart attack or stroke in lots of people, and it's not going to go away. But if you do follow a low carb approach, it might go away, and therefore you may well improve your metabolic health, and by way of conclusion, therefore improve your outcomes potentially. Only theory, not proven in science. Long-term safety, long-term efficacy. I mean, you're looking at well-being in the long term. People feel better for this, both in terms of coming off medication, in terms of how they feel from a sleep point of view, from a thinking clarity point of view, energy point of view. You're improving health parameters. You're keeping disease in remission or reversal. And we have studies, out to 5 years now, and lots of studies to show that this is actually a safe way to eat, and safe both in terms of outcomes for further events as well as health parameters. So, I think it's safe long term, and that's what it makes sense.
I do always wonder when I get posed with that question, what about long-term safety? And I'm like, well, if you're reducing excess body fat, you're reducing inflammation, you're managing insulin resistance, you're improving a whole lot of metabolic markers, like what's left in terms of long-term safety? But that sort of is a bit of a segue to my next question, and which is around nutrient sufficiency. So from a long-term safety, are people going to be deficient in nutrients? What's that all about?
Well, I'm going to quote a professor of nutrition from AUT on this one. And a study that she undertook a few years back where she looked at that, and that's Caryn, of course, yourself. And you demonstrated that, with a low carbohydrate diet, correct me if I'm wrong, macronutrients, micronutrients were well maintained as long as there's a well balanced, well thought out diet, way of eating. And there's plenty of guidelines out there to how to do this. So it's been shown in science as well, and reported on, that it's actually nutrients rich or adequate or sufficient. And certain foods, especially meat, are very nutrient dense anyway. So if you're eating more meat, that must be good. If you're a meat eater, you don't have to be a meat eater to do this. So I would add that. You can be a vegetarian or vegan as well. But yeah, just meat is certainly very nutrient dense.
Yeah, so I guess to summarize that, you could probably say that, and you and I are very much on the same page with this, is that we talk about whole food, low carb, whole unprocessed foods. So we talk about a rich source of different proteins. We talk about animal protein, plant protein, whatever, however you want it to be, but your animal protein is going to be the most nutrient dense. But we also talk about a rich supply of things like nuts and seeds, and also vegetables, not a rich supply of fruit, but certainly a rich supply of vegetables, particularly the non-starchy kind of green type vegetables. And if you I always quote Jeff Volek. When he started, this is kind of the father pioneer of the ketogenic diet alongside Steve Phinney, and they've always talked about a well-formulated ketogenic diet in their studies. And I think that it's important that everyone does their homework and make sure that they get enough variety within these foods in a low carb approach, so that they do have what we call nutrient sufficiency. And once that's sorted, then you shouldn't really see any deficiencies long term. So safe. Yeah.
Yeah, and I just want to add in I guess something useful. There's some apps out there, but probably the most useful app I've found is a free app from the UK from a general practice who do low carb called Freshwell. That's Freshwell, one long word. And it's a free app for people with type 2 diabetes. It's educational in terms of what they can eat. It gives you meal plans, and it's going to be nutrient complete. So it's just another tool that one can use. I'll just add that in at the point.
Yeah, awesome. That's a really good point, and it is a really good app. Okay, let's talk a little bit more about another area that people kind of get a little bit itchy about, and that is really the long-term adherence or the sustainability of this approach. Like people say, oh yeah, it's all very well, you do this diet for like 2 months and then you stop it, and people can't do this long term. What are your thoughts about those sort of comments, and are they myths?
Makes me want to groan, I tell you. It gets me every time. Look, the current standard American diet, the SAD diet, the diet we're recommended to eat by the Ministry of Health in New Zealand, doesn't work. People are getting fatter and sicker, and they have done for the last 60, 70 years. So that's not working. And it's not sustainable because it's not working, right? Some people can do low carb. Not everybody can, not everybody should. But for those that want to, those that can, it works, and they continue to do it. Or those you've had a chat with about it, start it, they stop it, and they come back to it quite often. And it's something that they can do. There's no subscription fee for it. They know what to do, or they get a refresher with a handout from me, for example. So it is sustainable for those that can do it. And I would suggest that, if you've got 10% of the population doing it, you're probably going to save a whole lot of money for the health service in many, many respects just by changing diet alone. And that's a fantastic thing. But there are people who do it for years and continue to do it because they feel so good on it.
Yeah.
Sustainability. I guess you're talking about the planet.
No. I was actually talking about the sustainability of the diet, or of doing that. I mean, I think, like, what are your thoughts about people's headspace? I think people need to realize, and this is not only with this way of eating, it's with any kind of way of eating, that if you're going to change your way of eating, it's really changing your lifestyle. This is not a diet that you go on until your HbA1c drops and then you go back to normal, in which case your HbA1c will go back up again. It's a real lifestyle change.
This is a really good question, a really good point, because the whole thing is about behavior change. I'm 60 something, and for the last 60 something years, I was brought up to have breakfast, which was probably porridge or wheat bix with milk and sugar. And then I had sandwiches for morning tea and lunch, and then I have muffin or something for afternoon tea, and then come home for meat and 3 veg, often starchy. We didn't have puddings, but a lot of households do. And then I got hungry because I was a teenager, so later in the evening. So, a whole lot of carbohydrate exposure over the years and habits. So we're changing habits, we're changing behavior, but it's really interesting, as a doctor, I don't tell people what to do, I advise them what to do, but you can actually persuade people to think about it. And it's done in a non-threatening, it's done in a commanding manner. It's done as a means of trying to make a change and explain to people that this is not going to be an overnight thing for most people. It's going to be a matter of learning this new behavior. And when they do it, they see the benefits of it. They say, look, I only eat 1 meal a day now. I'm feeling really good on that, or 2 meals a day. And it's everyone has their time. I mean, I saw a young woman the other day who has type 2 diabetes. She's got to have surgery. They say to her, look, your HbA1c is sitting at 92. We can't do surgery until you go on insulin. So she comes and sees me. I'm not her doctor normally. And we talk about the low carb approach. She's prepared to buy a CGM. She starts insulin at a very low dose. And now her glucoses are, where they were high, are now within range. And she's happy as anything because she's now going to get her surgery. And, she's been years saying to people, I'm not really bothered about my diabetes. I'm not really that keen, But with this timing, it's allowed someone who practices low carb to actually engage and to show that there's a difference. She was also needle phobic, so I got her to inject herself here in the practice. Various degrees of needle phobia, but it happened, and she did it. So it's a really good feeling from a doctor's point of view. That's the whole other thing to emphasize from a health practitioner's point of view. You're seeing positive results. It's so rewarding in that regard. And I really look forward to when she comes in now, because I actually going to have a positive discussion, positive engagement. And she's looking to come off insulin after the surgery once everything's healed, and then carry on probably with the low carb. So it is really positive. It's good stuff.
Yeah, that's great. I just want to make one point about that long-term adherence. I think, and again, you and I are on the same page with that, with this, is that there's a spectrum of low carb, and you can do moderately low carb, and you know, people stick with that forever. You can do the more extreme end of low carb, you know, keto for those who need it, and there are people that stick with that forever. But it's really up to the individual and their motivation and the results that they see that really influences how you know, how well they adhere, plus the support that they get as well, like the health coaching and the behavior change therapy and things that will help empower them long term.
The thing I would add to that is, you know, I often emphasize to people, I'd rather see you on a monthly or 3-monthly basis to see that you're eating the right way, rather than to see that you're on the right drug or need to increase the drug, right? To me, that's medicine. It's practicing medicine. And I think people get that. It's just nice to do that. And it's always a pleasure to talk to people about low carb. It breaks up your day from lots of mundanity to positivity. So yeah, that's rewarding.
Yeah, I know David Unwin refers to it as cheerful medicine. And hopeful medicine, which is really cool. And he was ready to retire. Now he's like nowhere near it, because he's just, you know, the job satisfaction he's getting is just immense.
Totally get that.
Yeah, so just before we finish off, Marcus, I've just got, I kind of just wanted to know if you wanted to bring up anything else that you think's important, or if we've covered the kind of key sort of myths and misconceptions.
I think just a summary to say that this is a very safe thing to do with certain precautions. And like we mentioned, you know, taking away some of the diabetes medication, some of the blood pressure medication, it's rewarding for both doctor and patient. It's not as time consuming as people think. I've got 15-minute appointments where I work now. I can do this in 15 minutes. It doesn't take long to introduce the notion to somebody and invite them back again. You know, so it's actually not time consuming as people think. And it's not hard to have the conversation either. You know, give someone a handout, talk about the concept, go and read it, see if you're interested, come back and talk about it if you want to, and go from there. So it's easy to do, but it is very, very rewarding. And the trouble is, as I said before, we're taught to prescribe for numbers. We're taught to prescribe for conditions. And it's a sad, sad situation that that's what we do because we're too busy to think about anything else. You know, to take the time to think about a new concept is time consuming. You know, and I think of my own peer review group, you know, they know what I do. None of them's actually asked me to show them how I do it, but I've been telling them about this for years, because we treat numbers, not people. And that's a sad thing. But, you know, don't want to end on a sad thing. The point is that there's a positivity to this. If you're interested out there, then I'm happy to talk to you about it endlessly, because I love talking about it. But also, it is a turnaround for your career. I'm towards the end of my career now, but it's turned things around in that regard. So yeah, positivity.
Awesome. That's great. Look, thanks, Marcus, for dispelling some of those myths and misconceptions today. I hope that session has been really useful for those listening. And again, thanks for ending on a positive note. So we'll go out on a positive. Thanks very much.
You're welcome. Thank you.